system. And then the final strategy for us is really improving health access and equity and trying to really drive that through all of these particular areas of work. Next slide. Just as a quick reminder, we have shown this slide many times, but we want to really reinforce that the collaboratives connected to the technical councils are really the core places of feedback that informs the board's decision for everything related to the Medicaid transformation efforts. And this is a really important point for us so that we're really talking about this mutually reinforcing feedback loop. The members of our leadership council and technical councils come from our collaboratives who are actually the on-the-ground activation networks for us. Next slide. And just a quick reminder, I think we have done just a fantastic job all around the region of getting the right people to our collaborative round table, but this is just a reminder of who we see as being important to actually both achieve our Medicaid transformation goals, but probably more importantly, how we improve population health. For the Medicaid transformation efforts, because so much of that work is really centered on getting the Medicaid delivery system ready for value-based payments, you will see continuously this emphasis on primary care and the behavioral health system. So they're in orange because there's a much greater sort of quarterbacking role that we see playing as we transform the delivery system. But we don't want to lose sight of what we all know to be true, that 80% of what makes you healthy doesn't necessarily happen in a clinical setting. So you see those important elements also reflected in the collaborative structure. Next slide. And then this final sort of context setting slide is a reminder of the types of activities that we are working on across this sort of multi-tiered approach. And so there's the Medicaid transformation projects. Those are the 4 core projects with which the region will earn dollars. We have added some additional requirements for our providers and the collaboratives based on our community efforts. So you can see that under ACH priority efforts. And then we are still holding some space for how we define individual collaborative goals and provider plans. Part of sort of holding those is as we think about how dollars will be earned in years 2 through 5 of the transformation, the Waiver Finance Committee and the board are sort of holding some dollars back to really think about how we accelerate movement towards not just these individual projects, but both our priority areas and collaborative level goals. I'm hoping all of this seems great review for many of you, but I'll just pause for 30 seconds here and see if there are any questions to be asked. You can go ahead and use the chat actually at any point during the presentation, but we'll do a quick pause here. Okay, I'm going to keep going.
This is Barb Schlimmer in Nebraska. I cannot seem to bring the slides up. Is there a place I can go get them?
Kim, can you, I think that was Barb. Can you have...
Yes.
As is always the case, Barb, we will make all of the slides available after this is complete on our website.
Okay, thank you. I'll just keep notes.
Okay, Kim, I think we're ready for the next slide. Next slide, Kim. Oh goodness, I lost our screen here. Okay, I think we're ready. Although Lindsay, I see that you're trying to ask a question. Maybe type it into the chat box. Okay, Lindsay, I'll let you text in or message in a question if you have one. So as we dive into the logistics of the budgeting process, I wanted to really, as clearly as I possibly could, really emphasize some key points that we are trying to be incredibly clear about so that no one gets confused. So I think you will see this slide about 1,000 times over the next 3 or 4 months as we try and shape this work. So the first point is, at this point, the board has only made policy decisions about year 1 funding. So years 2 through 5 funding have not been determined. And we would foreshadow for you that how the region earns dollars, so if you think about the 28 metrics tied to the 4 project areas, will not be what individual providers and collaboratives have to report directly to us. There may be some that we emphasize as being important, that there will be ACH reporting, but that differentiation is going to be a really important point as we think about this. As we've started to think about years 2 through 5 funding, I would expect that we've not made any board policy on this, that a portion of the dollars will be allocated based on both volume and increased access for our equity efforts. And that may be in service to ethnically diverse populations or other focuses that help us meet our equity goals. Years 2 through 5 will be a combination of pay for performance and pay for reporting. So if you think about the pay for reporting, the completion of the behavioral health and primary care assessments that you did, you have completed that, so you have earned pay for reporting dollars. As we move into some of the region's dollars being tied to pay for performance, we would expect some of that to translate into how individual providers and collaboratives will earn dollars. And things that might be part of pay for performance could be a metric related to ED utilization, or increase in moderate to highly effective long-acting reversible contraceptions kind of thing. So just to kind of give you a sense of performance versus reporting. I would expect that through year 5, that there will be pay for reporting earning potential, because a lot of the work that we are envisioning happening is actually process improvement. And if you think about a theory of change, our expectation would be, if you do these steps in the process, then over a period of time, we would see improvement in a health status related performance measure. The Community Resiliency Fund, so that is, I think, one of the most exciting things that is coming out of these transformation funds. And the board has agreed to set aside 10% of all of our project money dollars earned to fund this Community Resiliency Fund. It is important to note that we've not made any decisions on this. So I did notice in our last waiver finance committee some questions about, so that's for the social determinant of health partners, or you've decided this. We've actually not decided anything. What we've been doing over the last 3 months is really getting community feedback via our technical councils and other conversations about how those dollars could most impactfully be invested. And that at this point, we are not saying this is the social determinant of health numbers or dollars. I would say that it was approved by the board with the idea that the Community Resiliency Fund would be helping to support the linkage between social determinant of health and the healthcare delivery system. So again, we have not made any decisions on that. The next key point, and this is starting to get us closer into the budgeting exercise that we have ahead of us, is as primary care and behavioral health providers think about what they will need from community partners in order to move more and more of their contracts into a value-based payment arrangement, you should think about what both you will need and what those partners will need in doing that. I probably should have this next bullet in about 42 font, because I think this is part of what really differentiates this transformation effort from sort of typical grant making dollars. Is the budget that you are submitting is not for an up or down, the ACH is going to fund X dollars from your budget. The budgets are really designed to help us develop policy. So we will not be funding your budget. We will not be funding your projects. We will use these budgets to develop the policy of how providers and collaboratives will earn dollars. And once you've earned the dollars, it's really at your discretion to invest those dollars in the ways that allow you to continue to move down the health transformation process. So I'm probably going to pause there and say that again, that we are not funding the budget that you are submitting. We encourage you to think about these budgets as a tool for how you would get the types of investments you will need to be ready for both value-based care and just the changing landscape of healthcare. So maybe I'll pause there and see if there are any questions or comments in that way. It feels really important to me that these key points be super clear to all of our partners.
Okay. So Allison, this is Tom. Wait. This is Tom, but up in Honduras County. So the budget you're talking about is going to be a collective budget that's kind of comprehensive, collaborative to do bidirectional care?
No, I would think about this as your health system budget to accomplish the setting requirements that are laid out. We might need to mute while I'm answering the question. There's a lot of feedback. The budget should be for the individual provider, but you should have a lens towards the set of partnerships you're going to need to accomplish the setting requirements for each of those project areas. But we are not, if you say I need $50,000 to do X, this budget process is not going to give you the $50,000 to do X. We are using this budget process to inform the policy of how you will earn dollars, and then you would decide you've earned the $50,000 and you're going to put it in that way, to that line item. This really is intended to align with each individual organization's sort of strategic plan or business plan for how the system is transforming. It is not designed to be, I'm going to pay for a community health worker to do chronic disease management. You may decide you use your money in that way. Maybe unmute now, Kim, and see if that got
Yeah, I guess. Yeah, I don't know. To me, you're going to have to try. You're going to combine all the individual providers and try to come up with some policy determination based upon the silos that we're still in versus how we're going to do it as a collaborative.
Yeah, I think that is a big piece of work ahead of. Can you mute us again, Kim? I'm sorry. That is a big piece of work ahead of us, and we will be reviewing all of the provider plans, as well as our technical councils will have a set of volunteers reviewing the plan, and then we will be working with our consultants to be looking for what those themes are. Part of the reason that we had the collaborative set, what I'd say is sort of collaborative strategic direction before provider plans, was to inform what your provider plan looks like as it relates to the collaborative plan. And then once provider plans are complete, we would imagine that the collaboratives come back together and sort of do some further refinement on that. It's really important to think about this as an iterative process and not a one and done type of thing. But yes, it's going to be a big it is going to be a big lift to look across 48 partnering provider plans and budgets to identify where there are common gaps across the region, that instead of funding through individual collaborative efforts or partner efforts, we might think about funding through regional infrastructure, as well as sort of honoring 48 different business approaches to this. What we do feel confident in is that the setting requirements are creating a similar approach, and that we will see some commonalities come through in that way. Other questions or comments? Otherwise, I'm going to keep moving us along so we make sure we have enough time for the actual template. Okay, let's go to the next slide. We've had a very strong desire to get the maximum amount of investment to our providers and partners as soon as possible. You'll see on an upcoming slide the dollars we have left to distribute post-assessment / provider plans to start to address our identified gaps. And that we are trying to frame all of this work as it relates to both health system transformation, but also getting ready for value-based payment adoption, which really does require a different set of partnership between the healthcare system and the social determinant of health system. Next slide. And then I am not going to spend too much time on the principles, but more to just reinforce that as we have gone through this process, these guiding principles have been embedded in our decision. Next slide. And then I just want to remind folks of the dollars that are available. And you will see here in year one, we are in the allocation process of the 3.32 FIMC funds and the 11.3 project funds. My next slide will show you sort of where we're at in terms of dollars being released and so forth. The provider plans that you are putting together right now will allow us to submit our regional plan in October that potentially earns us 17.9 million in project funds. So we're hopeful that all of you will take seriously this planning process and the ability for us to create a cohesive and impactful regional strategy based on what your individual provider plans say, so that we can really maximize those dollars. As you can see, next year is our high year of earning potential, and the final year of which pay for reporting is playing out. So as we move into years 3 through 5, the dollars are less and more of them are at risk for the pay for performance metrics. Additionally, you will see that we have $2.2 million in value-based payment incentives available. And that is as we meet the increasing threshold of contracts, Medicaid contracts in a value-based payment environment. And the goal is by 2022 that 90% of all of our Medicaid contracts will be in a value-based payment environment or structure, and that 50% of those contracts will have some risk involved in them. So still a lot to be determined, both for you individually negotiating with MCOs, but also as well with the healthcare authority further defining what a value-based payment contract actually looks like. For year 2, we have the potential to earn $400,000. So we're just trying to encourage folks that we want to keep moving down that goal as it best aligns with your business strategy. Many of those dollars are actually tied to pay for reporting metrics, things like you completing the VBP survey that the healthcare authority just sent out in the last week or so. I think the allocation of 55% of our project money, 30% to regional, is fairly familiar to everyone. Part of why I want to just highlight the potential of $31 million over the 5-year period is to really appreciate the 48 behavioral health and primary care providers that we have in the system, and then another 45 or so other key partners from the community. And that when you start dividing up $31 million, it is not a huge amount, and how important this process is, both the budgeting and the planning process, to you really thinking about your long-term vision for being ready for value-based care, whether you're talking about Medicaid or Medicare or your private pay contracts, and that this is flexible dollars to help invest in that infrastructure, but this is not funding transformation fully. Next slide. I think many of you have seen this. I think we've highlighted this. I would just say that we've got about $9 million already allocated out to the region of that 14 million that we have available to invest this year. Next slide. This just gives you a sense of the dollars we have left to allocate for year 1 dollars. It's about 4.3 million of project money. It is important to note that our year 2 funds will not be available until May of next year. So we will be trying to push out this 4.3 million as quick as we can, but also we are going to have a bit of a lag period from now until May, when the next phase of, or next buckets of dollars will be available, which gives us some opportunity to be really thoughtful about how we're going to allocate those dollars. Next up. And then there's about $1 million left in our FIMC incentive pool, and I believe that we will be very aggressive in getting those dollars allocated as soon as our provider plans are in place and we can see where the smartest investment is to really close any outstanding gaps for our behavioral health partners as they get ready for IMC going live January 1, 2019. Next slide. And then I just want to give a quick overview of decision points that are coming forward. So between now and the end of September, we're really working on making sure that we've got all of the dollars allocated actually in the hands of our partners, so they have some flexibility in the planning process as we get ready for year 2. The Waiver Finance Committee will be making recommendations to the board October, November-ish around the incentive dollar payments for year 2. And it's possible that we will be setting a structure that will be true for years 2 through 5. We're still in the development phase of what those metrics look like, because we want them to be very grounded in what our provider and collaborative plans look like. So this is one of the points that I can only imagine the level of frustration as you're trying to think about how to do a budget when you don't know how big the bread box is, that we really are trying to be strategic in how those incentives are allocated or earned by the region, and want that to be really grounded in your individual plan. So we will have a lot of communication through this decision-making process for folks to give us feedback based on what we saw from the plans and where we think that emphasis needs to be made. I expect that our FIMC funds, as I mentioned, we will aggressively try and get those out the door early in the 4th quarter. We will be recommending a community resiliency fund process to the board. I had hoped that we would be running that process in the 4th quarter of this year. I think realistically, in order for this to be the most thoughtful and to make sure we've woven together as many possible other funding sources into this, that we're probably looking at 1st quarter of 19 to have the community resiliency funds released. And then, as I mentioned, our year 2 funds will be available in May of 2019. I do expect that you will have a clear picture of what it will take to earn those dollars prior to the end of the year, so that part is, you may not have those year 2 dollars, but you will know how they could be earned. Next slide, and then I think I am ready to turn it over to Kathy. But before we do that, maybe I'll ask if there are any questions that are coming on the chat box here. I'm looking quickly, and I don't see anything. As Hadley is noting, the echo comes from when you have both your sound on your computer as well as you've dialed in. So if we can use the chat box, I think that's a little bit easier for folks. And with that, I am going to turn this over to one of our new favorite friends, Kathy Homke, who is with Health Management Associates and ran a similar organization to Better Health Together in New York through the formation and execution of their Medicaid transformation. So her war wounds, I think, are still healing, but just an amazing human being to be helping us with this work. And I would sort of assure our providers that there are an awful lot of times where she is saying, well, that's an interesting idea, Allison. Let's just make sure we consider this context of how actual transformation happens. So with that, I'm going to turn it over to Kathy. And again, any questions you have as we go along, add them into the chat box.
Thank you, Allison. It's been a pleasure to work with you and your team. Can everyone hear me okay? And if not, I'll assume a yes. Next slide, please. So we're just going to briefly discuss the principles of contracting. And Each partnering organization signed a standard partnership agreement with a financial executor when you were set up in the portal. So that agreement sets forth basic requirements regarding audits, record keeping, retention, and ensuring that there's sufficient funds to support the data that's submitted, as well as, you know, maintenance of records, which is common in all organizations. So that's just really kind of the platform. And I think it's important to note that while these are requirements in your standard partnership agreement, and we'll talk about this briefly, is that the budget is not a reporting requirement. And partners, this will be designed so that partners can spend their funds at their discretion. But again, it's important to be mindful of these basic requirements. Next slide, please. And as we start to move forward with contracting, as we continue to design the funds flow, it's important to note that BHT is not seeking to inconvenience partners with burdensome reporting requirements. We will require certain information, certainly to fulfill our reporting requirements, to meet pay for performance as well as pay for reporting. But BHT aims to keep this reporting simple, flexible, functional, and useful. So as we move to the next phase of this contracting process, we anticipate that we will evolve these requirements, and there will be addendums to the standard partnering agreements that will reflect this evolution of the payment strategy. Next slide, please. So I'm going to briefly review the budget template, and really just to reinforce, you know, as Allison has shared, the budget template is a useful tool. It's designed to be useful to the partnering providers, serve as an exercise designed to help your organization think about the necessary resources and costs to implement these transformation plan activities, really intended to be used to support a business model. And we would anticipate that many of you, as you implement and design these transformation plans, there will be an element of strategy and a required business model to support that strategy. It's important to note that the budget's not a grant proposal. It's really designed to be a power assist as you move towards value-based payment over the course of the project and to achieve the goals. Also, we also recognize that project funds will not be enough to support all transformation activity. Rather, you'll be looking to braided funding sources to really kind of fill in some of those gaps. But more importantly, it should be recognized that partnering providers will also have opportunity to leverage financial resources based on the implementation of these projects. And this could be in the form of increased revenue, from outpatient and primary care, variable cost savings, operational efficiency due to greater scale as we look broadly across the BHT region, reducing fixed costs, as well as moving it forward with value-based contracts. And as I just shared, the budget's not a reporting requirement. Rather, partners will have the ability to spend funds at their own discretion. Next slide, please. So what will BHT do with the data? Well, BHT is looking to identify ways to create efficiencies, identify gaps, so that investments can be leveraged with an eye towards strategic value-added partnerships. As Allison shared, you know, as you develop your community linkages, we want you to think about what you and your partners will need and identify areas that will require a heavy lift. Again, to reinforce, this data will influence BHT policy as well as we've looked to state policy. We're going to look for the commonalities, find ways to leverage resources and align and distribute costs, identify gaps in resources or infrastructure that may need to be filled in order to implement the plan. Again, what requires a heavy lift? Inform the incentive model, and again, find evidence of collaboration across partnering providers and organizations, and look to funding mechanisms and policy that will reinforce that. Next slide, please. So this is just a snapshot of the of the budget template. And again, these transformation plan budgets are for informational purposes only. And it's not expected that project funds will fully cover these costs, but providers should build their financial plans with a view towards weaving together funding to meet setting requirements, not pitching specific project ideas. So for each budget category in the template, BHT is requesting partnering providers to identify estimated costs associated with the transformation plan activities, along with costs associated with project management and convening. And so we also, as you'll see, built in a 10% administrative cost so that we can recognize the cost of your cost of implementing. And so with that in mind, we do not want you to build in those anticipated costs. So this will be across the board. We'll be looking at in consideration of the budget. We'll review the plans with an eye for whether or not these providers are able to meet the pay for reporting and pay for performance measures. Again, as Allison shared, this is going to be an iterative process. As we build transformation plans, collaborative plans, look at budgets across the partnering providers, look at really kind of get a good sense of how we can, again, create efficiencies, identify those gaps, move towards a strategy that really brings together value-added partnerships. Next slide. So what I've done is just, there's a series of examples to kind of help inform your approach to the budget template. These examples contemplate transformation plans and potential resources needed to implement associated elements. So one of the requirements is that partnering providers identify and budget for a transformation manager. This executive will serve as a point of contact and will be accountable for the success of the transformation plan. So we have Transformation Jane, the Director of Transformation Initiatives. And so this is for many of you that work in finance will really should know and understand the mechanics of the calculation. But just as a reminder, we're looking for total hours employed, what their annual salary is, and then we're looking for you to use an average organization benefit rate. I just put in 28%. It could range 22%, 20%, 28%. So that's just going to kind of give us an overall sense of what that benefit rate could be. And then annual salary, and then we're looking for the percentage of salary devoted to the transformation project activities. So this is in total anticipated that, time and effort that Transformation Jane would serve in this capacity, but we would also look to you as you look across each of the template and the transformation plan activities that you would think about how the amount of time would be spent by Transformation Jane to accomplish these services. Next slide. So this is the example of, under transformation plan, bidirectional integration of care. Collaborative Tom, care management manager that's been hired to oversee the element that really looks to form an integrated care team and implement a collaborative care model, should that be chosen. Again, using the mechanics of an hourly employee, looking at the percentage of salary devoted to care coordination. In this case, I've identified 100%. What's important to know is that partnering providers should not request funding for positions that are currently funded within the organization. This is, as you think about the model, think about what is going to be required as you implement this new element under your transformation plan. Next slide. Using the transformation plan example of bidirectional integration of care, again, one of the elements required is access to psychiatry consultation services. Psychiatrist Sam will provide in-person psychiatric consultation, including case review, assessments of challenging patients, and caseload review. So under a contracted agreement, their estimated time and effort would be 24 hours per week. The projected cost of those services would be $3,600, and then with total annualized contract cost of $86,000. So again, partnering providers should not request funding for positions that are currently funded within the organization, and I should really clarify, not request, but really identify. So the thinking is really, as we shared, is find opportunities to leverage resources, but I also identify gaps in resources that may need to be filled. Next slide. Equipment, data, and analytics. So BHT recognizes that a robust healthcare-related data sharing platform, along with quality improvement and utilization analytic capabilities, will be fundamental to the success of this initiative. So it's important to note that there'll be assessments of IT capability, including applications, software used, data used, including plans for IT infrastructure, addressing confidentiality, consent issues. And so, data will inform dashboard development, clinical data sharing, cost and quality reports for relevant stakeholders. So the completion of the template is going to provide an opportunity to look for those commonalities and way to efficiently and effectively leverage these resources. So an example might be under the transformation plan, chronic disease management and prevention, organizing patient and population data to facilitate efficient and effective care. So opportunity to initiate a patient tracking system, which could easily be a standardized Excel template, but the implication might be costs associated with a vendor to create this template within your electronic medical record platform. So these are the kind of things that we want you to think about as you start to implement these plans, and how to identify those potential costs within your budget template. Next slide, please. So for an overarching example, I looked at the transformation plan for addressing the opioid use public health crisis. So element 1 is educating individuals who use heroin and or prescription opioids, and those who may witness an overdose, on how to recognize and appropriately respond. So OPAL Educator is going to provide technical assistance to first responders, chemical dependency counselors, and law enforcement on opioid overdose response training and lock zone programs. Also assist emergency department to develop and implement protocols on providing overdose education. And these are all built in the template as you start to kind of think through these elements and how best to really budget your resources, allocate your resources. And so using projected personnel services calculation, a 0.5 FTE to prepare materials, conduct the assistance in education, identified $30,000 for OPAL's personnel costs. And then as you're looking at these elements, we want you to think, okay, within your region, maybe 30 miles per week, calculate the rate per mile. Again, this is technical for some of you. Over the course of 30 weeks, those costs associated with the technical assistance. And then looking at an opportunity to form either technical assistance or learning collaboratives, and those costs associated with that, such as space, beverages, and then of course materials. So when you think about the strategy and the implementation needed to support this transformation plan and associated elements, you're looking at potential $32,000 in projected cost. So again, this is just really kind of to help you think through your approach to the template and accomplishing these transformation plan activities. Next slide. So really the biggest bang for the buck. So looking across, and this is as we, through the course of this iterative process, and start to look at the templates that are being shared, is we're going to try to identify, how we can best distribute these funds. And so again, identifying gaps in resources or infrastructure that needs to be filled. It could potentially be an investment in a workflow design. Especially working through collaborative or the BRE model, is there a way that we can create some efficiencies? Also looking at evidence of collaboration across partner, provider, and organizations. That could be through shared space, co-location under the model. Also opportunities to leverage resources and align and distribute costs, which could be learning collaboratives, training, communication and materials. Also standardizing tools, such as performance dashboards and screening tools. So we'll be looking for evidence and opportunities. And this could occur through a shared or central services, could occur through support services. We'll be looking at the collaborative plans to determine how best to really leverage the resources and essentially get the biggest bang for the buck. Next slide. Great. And I think we have some time to spare with questions. Allison, I'm not sure if you want to just kind of take it quickly from here.
You bet. I'm not seeing any questions in the chat box, but maybe I'll just check in with Kim and Hadley to see if they are seeing any. Oh, Lindsay's trying to talk. I see, folks. It's telling us that you're
the room, so if anybody wants to ask a question, go ahead now.
I see Kim and Ron, or Lindsay and Ron trying to ask questions, but we're not hearing you. I hear some loud typing, so I don't know if we're about to get a couple of questions on the chat.
We're doing those chart audits.
Yeah.
I'm not sure if, like, what they're looking for, to me, it looks like we're not doing well at all.
Okay, I am going to make a Friday the 13th call here that Ron and Lindsay, I think you probably have some questions. If you want to either post them in the chat box or give us a call and we will answer them and include them in our FAQ so that everyone has the benefit of being part or hearing the answers to that. With that, I think we are going to give you 4 minutes back in your morning and remind you that our team is available to answer any questions, go through the process. We know this is a lot of work and we are here to help provide as much clarity as we can. Thanks so much, everyone.
Thank you.